All right. Well, good afternoon, everybody. Welcome to today's NTAC session entitled Transition to College for Youth with Psychosis, a case-based discussion. We're so happy that you are taking time out of your busy schedules to join us today. Before we get started, we do have a few housekeeping items to go over with you. And first of all, we would really love to learn more about you. So if in the chat box you could enter your organization, your role, and where you're located, that would be really great to be able to see who we have here with us today. Let's see if I can put the chat up. Okay. As part of our session, we have to provide you with this disclaimer. This presentation was prepared by NTAC under a cooperative agreement from SAMHSA. While this event is supported by SAMHSA, the contents are those of the authors and do not necessarily represent the official views of SAMHSA, HHS, or the US government. While we hope there are not any security issues that happen today, in the event that any may occur, the session will immediately end and you will be notified by email how to rejoin a new session. Thank you again for attending one of our NTAC sessions. Listed here are all of our incredible national partners that have come together to utilize their expertise and their subject matter knowledge to help inform the field by creating products, resources, and sessions like this one to enhance the behavioral and mental health fields. As a center, our vision is that all children, youth, and families living with and impacted by mental health challenges will have access to the resources and opportunities they need to thrive in a comprehensive and equitable system of care. We serve a wide cross-sector audience, including everyone from state leaders to providers, to school workforce, infant and early childhood providers, community-based providers, peer supervisors, family partners, youth partners, and much more. Our services range from individual consultation to more in-depth sessions like the one we're offering you today, to peer learning exchanges and tools to help you. Our aim is to really create those outlets for communication, collaboration, and resource sharing among all of us. Please also to make sure to check out all of our resources and archived presentations on our website, or go to the contact us link on the website to request a consultation or training. And Carrie has put the website in the chat box for you. Okay. Before we get started, we want to address some commonly asked questions that come up during our sessions. So before we start, we can get you some answers to those questions. In the follow-up email for today's session, you will receive a certificate of completion, a link to the recording of the session, and a copy of the slide deck of the presentation that is being shown. So now that we've made it through those housekeeping items, I want to welcome you again to today's session, Transition to College for Youth with Psychosis, a case-based discussion. I'm going to start by introducing our presenters. Dr. Apurva Bhatt completed her undergraduate and medical school education at the University of Missouri, Kansas City's 6-year combined BA/MD program. She went on to complete her residency training at the University of Missouri, Kansas City Center for Behavioral Medicine's Adult Psychiatry Residency Program and graduated Child and Adolescent Psychiatry Fellowship at the University of California, Davis. She is the co-chair of the Early Psychosis Work Group at the American Academy of Child and Adolescent Psychiatry and will be joining as a clinical faculty member at Stanford University this fall. I'm Dr. Olivia Hamra. I'm a child psychiatrist and an assistant professor of clinical psychiatry at MedStar Georgetown University Hospital. I work with emerging adults in our outpatient transitional age clinic and in school-based mental health through the MedStar Center for Wellbeing in School Environments. My clinical research focus is in early and first episode psychosis, including the prevention of psychosis, treatment of clinical high risk for psychosis, CBT for psychosis, metacognitive therapy for psychosis, and pharmacotherapy for psychosis. Dr. Jane Elberg is an assistant professor of clinical psychiatry at the University of Buffalo, where she also serves as the associate training director of the general psychiatry residency program. She's the program director of On Track New York at ECMC, a coordinated specialty care program for young adults recovering from first episode of psychosis. And finally, Philip Thomas is a supported employment and education specialist at ECMC in Buffalo, New York. He has over 8 years working in the field of education. He takes time and care to consider the goals of each participant. Phil has extensive experience working with schools, universities, and employers, and aims to help participants experience success in these areas of their lives. So welcome all of our speakers today. Thank you so much for being here. By the end of the presentation today, we hope that you will be able to recognize psychosis as a continuum of symptoms, identify domains of functioning that are important for assessing college readiness, identify characteristics of colleges and universities to consider when determining a best fit for a young adult with psychosis, knowing where to access research and to know where to access resources both in schools and in the community for supporting young adults with psychosis and their transition to college. Okay. So now I'm going to hand things over to Dr. Bott, and we're going to present a case.
Thanks, Olivia. So we're going to start out with a case of Ethan. Ethan is a 16-year-old young man. He is adopted and lives with his adoptive mother, father, and a younger brother. But until recently, he was doing well, and his parents had no concerns about his well-being. He was an A/B student in school, played soccer for the school team, and had several close friends. Next slide. About a year ago, he began to withdraw from his friends, and he had a lot of trouble focusing in school. His grades started to drop to C's and D's, and he decided to quit the school soccer team, which was highly unusual. And his teachers noted that he was struggling to focus and was appearing suspicious, especially when they would offer to help him. He was avoiding eye contact and was noted to be appearing to be talking to himself. Next slide. He starts telling his parents that he cannot go to school because the Illuminati is following him and communicating threats to him telepathically. He throws his phone away and stays in his room, not leaving even a shower or eat in order to keep himself safe. His parents were very concerned about his mental and physical health, and they bring him to the emergency department. Ethan is admitted to the inpatient psychiatric unit for 7 days, where he is diagnosed with schizophrenia, started on antipsychotic medication, and referred to an outpatient psychiatrist and therapist. So if folks, we want this to be a little bit interactive. So please put in the chat, what comes to your mind when you hear the term psychosis? Hallucinations, altered reality, having a different reality. We've got, a lot of mentions of delusions, paranoia, seeing and hearing things, internal voices, stigma, delusions and fear, having some thinking problems, mental illness, negative thoughts is a big one. Unable, to tell the difference between reality and hallucinations, or having a break from reality. So psychosis is a term that I think is sometimes thrown around in pop culture. People will often use the term psychotic, and I think it's really interesting to see just what people's thoughts are, what comes to mind. So NAMI, the National Alliance on Mental Illness, has defined psychosis as disruptions to a person's thoughts and perceptions that make it difficult for them to recognize what is real and what isn't. So the DSM-5-TR, which is the big book that the American Psychiatric Association publishes every so often, they define psychosis as having 5 symptom domains, and starting with hallucinations, delusions, disorganized speech and behavior, and negative symptoms. And we're going to kind of briefly go over each of these symptom domains as these are what is used when somebody seeks out psychiatric care. You'll hear about these terms kind of thrown around. So we'll start with hallucinations. So these are perceptions in the absence of a stimulus. And so there are many different types of hallucinations that can occur. There could be visual ones where they're seeing things, auditory where they're hearing things, olfactory where you smell certain smells. There could be tactile where you feel things on your skin or on you, and then somatic where you feel things inside your body. It's really important to distinguish hallucinations from these other things. So having heightened perceptions, for example, when you're walking in the forest at night and you're kind of on alert, and you hear a noise or a stick cracking in the distance. Having sort of PTSD related symptoms, so hyperarousal, hypervigilance, being kind of on alert, feeling numb or kind of out of your body as related to trauma symptoms. Illusions, which are common. This is like a real stimulus, but it gets misinterpreted in the brain. And then there's these very common hallucinations called hypnopompic and hypnagogic hallucinations, which happen when you're falling asleep or waking up in the morning. And those are very common. Next slide. The next symptom domain is delusions. And these are defined by the DSM as a rigid, unshakable belief that is inconsistent with common or cultural experience. Delusions can be non-bizarre, meaning quite plausible. For example, like I feel like somebody is monitoring my phone. We know now that these tech companies do actually like collect data. So that would be an example of like a non-bizarre delusion or of a non-bizarre. And then implausible is the other type where it's somebody has a belief that's not really logically possible. There are many different subtypes of delusions as well. And those include like persecutory or paranoid, where someone feels unsafe, grandiose, somatic, and then there's the ones where some folks experience a loss of control of their mind or that they can't control their own body. The next symptom domain is disorganized speech, and that can vary. So sometimes it can be from switching from topic to topic, and that term is called derailment or having loose associations or providing unrelated answers, which is also known as tangentiality. Speech that is difficult to understand is what disorganized speech is. And mildly disorganized speech is common. Like if you catch me on a sleep deprived day, I might have a little bit of disorganized speech. But for this symptom to fall into the psychosis spectrum, the speech symptoms must be severe enough to impair effective communication. And so when you're talking with the person, you're really kind of scratching your head and having a hard time understanding what they're trying to communicate to you. And it's really also important to distinguish disorganized speech from someone's baseline speech. The next symptom domain is disorganized behavior. And this can manifest in a variety of ways, ranging from, as the DSM says, a childlike silliness all the way on the far side to unpredictable agitation. It's important to know that most individuals with psychosis are not actually aggressive or anything like that, and are actually more likely to be victims in those situations. Disorganized behavior can also include catatonic behavior, where they have sort of a decreased reactivity to the environment, where they might appear frozen, they might be moving physically very slow, or appear stuck. And then on the other side, they could have excitatory behaviors where they're moving around a lot, having purposeless movements, maybe echoing your speech a lot, or having a lot of repetitive movements. I just realized I'm not sure if my video is frozen, but sorry about that. I will just keep going though, because I'm almost done here. Let's see. I'm not sure why it's frozen, but negative symptoms, moving on to that domain. Those are having reduced emotional expression. So reduced eye contact, reduced intonation of speech, maybe even having reduced hand gestures or body gestures, having low motivation to do activities, having reduced speech, and anhedonia, or having a reduced ability to experience pleasure, and having a lack of interest in social interactions. One thing that I will mention is, negative symptoms are the ones that are more problematic for individuals with psychosis, and we don't really have really good treatments for this. There's no good medications that can help treat these things, and these are the ones that often cause a lot of impairment, especially in academics. Next slide. And I apologize, I don't know why my video is going on and off here. Sorry about that, guys, but I will continue. So it's really important to know that psychosis symptoms, all of those 5 symptom domains that we just talked about, they can occur on a continuum. And so kind of at the very bottom left here, we have these symptoms that can occur within cultural norms. So these are symptoms that don't really cause much distress. They're very rare, and they don't really affect your behavior or functioning. And so, for example, a really good example is if you grew up in an area where there are basements, and having to run down to the basement and grab something for your mom, and then you're running up the stairs because you're scared of the monster that is theoretically behind you trying to grab you. You can almost feel like that entity is there. And so that would be, I think, within a sort of a cultural norm. Moving along the spectrum here, or along this continuum, as things get a little bit more frequent, these experiences may cause more distress, but the person is still able to sort of question this experience, and it has little effect on their behavior or functioning. That's the second column here, and that falls within sort of the attenuated or subthreshold psychosis. As that increases with frequency or distress, but now maybe the person is having some difficulty questioning this experience, or having some effect on behavior or functioning. Now that's still sort of within the attenuated subthreshold symptoms. As we move into the full threshold psychosis symptoms, these are symptoms that occur very frequently, sometimes several times a day or several times a week. They cause significant distress. The person is convinced that this is real, and it causes significant impairment in functioning or behavior. So that's kind of just, it's important to know that these symptoms occur on a spectrum or a continuum. Now, it's also very important to know that psychosis is a symptom, and there are many possible causes for this experience. It's not just that it's schizophrenia. There could be many other things. So severe symptoms of PTSD, for example, can look like psychosis. Personality disorders, maybe mood disorders like depression or bipolar disorder, can have psychosis symptoms accompanying the mood symptoms. You can have substance use that can produce psychosis symptoms. A lot of medication side effects like steroids and other things, other medications people could be taking. There are neurological conditions that can cause psychosis type symptoms like seizures or encephalitis, having some sort of a brain mass, autoimmune conditions, most commonly lupus, having delirium, which is usually a medical condition, thyroid disease, especially like hyperthyroid states, infection, and then more rare conditions. And so if somebody is coming in with psychosis symptoms, it's really important to make sure that they are receiving a full medical workup before we jump to like, this is a psychotic disorder. And definitely insomnia, yeah, that can also produce psychosis symptoms. It can make it harder to figure out what's going on. And with that, I'm going to pass it on to Olivia while I troubleshoot my video.
Okay, thank you so much, Dr. Butt. Let's go back to Ethan's case. So he was in the hospital, and now he's home, and he's been taking his medication, which is aripiprazole 15 milligrams daily, consistently, and he's receiving care at a first episode psychosis clinic, which is a coordinated specialty care program. So I want to start out just by asking you all, what is recovery from a first episode of psychosis? And feel free to put whatever comes to mind in the chat, because I think this is something that comes up, but sometimes it can be kind of a vague concept. So I want to make sure people understand this. What comes to mind when you think about recovery from a first episode of psychosis? Enjoying life, person-centered, managing symptoms, therapy. Yeah. Peer support, really important. Independence, relief from symptoms. Baseline, overall functioning. Yeah. So it sounds like you all have a pretty good idea of some of the things that are involved in recovery. And I also just wanted to mention that recovery is something that can be very personal to an individual. And so it's unique to each person who you're working with. Yeah. Oh, wow. Thank you. Aurelie, I think I said the exact same thing. It really depends on what an individual's goals are, and how we can work with them to achieve those goals. Usually recovery includes some aspect of these things listed here. So regaining a sense of control over psychosis. So having that feeling that you're able to do something about it. Creating a lifestyle that supports mental health and mental wellness. Restoring a sense of self. So I think some people said back to baseline, like feeling like you're back to yourself or feeling better about yourself. Getting to a point where your illness is not a dominant part of the day-to-day living anymore. Feeling more confident in social engagement, like being able to talk to people and engage in relationships that are meaningful. Going back to work or school is usually a big part of recovery. Establishing independence as a young adult. A lot of times the first episode of psychosis will happen during those young adult years. And so establishing that independence is such an important part of development at that time. But then also just understanding that recovery, really, it's an ongoing process. It's a journey. There's going to be times where there's growth. There's going to be times where there's setbacks. There are going to be times where it feels like things are changing really quickly and there's so much changing at the same time. But then also times where it feels like not much is changing. And so just kind of working through that process and having support in that process. One really important myth that I like to debunk is that a lot of times when people hear a diagnosis of schizophrenia, they assume that they will never recover, or their family or friends or other people around them assume that they will never recover. And that's just not true. In fact, most people with schizophrenia do achieve some form of recovery, and recovery becomes like, it's the expectation and the norm in schizophrenia treatment. And outcomes, you can tend to kind of divide into this like rule of quarters. 10 years after a diagnosis of schizophrenia, about 25% of people will have no relapse. 25% of people will have some relapse, but still have close ties to the community and are doing very well. About 25% of people will be in some form of recovery, but will need pretty intensive treatment and support to maintain that. And then the last 25% of people, the people who really struggle and don't do well. So about 15% of people will have some severe impairment from their schizophrenia, and 10% will die by suicide. So it is still a significant number. There's still a lot that we're looking into in terms of how to create better outcomes with a diagnosis of schizophrenia. Part of that is identifying schizophrenia symptoms early. So like how Dr. Bott presented that spectrum of symptoms, like recognizing those symptoms early, treating them early, that reduces what we call the duration of untreated psychosis, which creates much better outcomes. And then the other thing is connecting people with coordinated specialty care. So I want you to give a thumbs up in the chat if you've ever heard of coordinated specialty care. Okay, good. Some people. Yes, I work in one. Okay, good. All right. A lot of people have heard of this. There's people who work in coordinated specialty care. That's wonderful. Okay. For anyone who has not heard of it, I'll briefly give an overview. Coordinated specialty care is a recovery-oriented treatment program that's designed for individuals who are experiencing a first episode of psychosis. Different CSC clinics might offer a different range of services, but in general, they all offer these core services. The first one is individual or group psychotherapy, and that's really meant to be tailored to a person's individual recovery goals. A lot of times it's cognitive and behavioral therapies, therapies that are going to teach that individual knowledge and skills to build resilience and to cope with different aspects of psychosis, while also achieving those personal goals. Another core feature is family support and education programs. We know that the more that family members and natural supports are involved, the better prepared they are to help those loved ones in their recovery process. So it's really important to teach family members not only about psychosis, but also about coping and communication skills and problem solving skills, so that they can really support their loved one with schizophrenia. There's medication management. Not everyone with schizophrenia takes medication, but the majority, or a lot of people do. And so it's really important to have a medical provider like a psychiatrist there to tailor medication to a person's specific needs, selecting appropriate types of medication, doses of medication, discussing method of administering medication, like if someone wants to take a pill every day or do a monthly injection of their medication, and to talk about the different risks and benefits associated with medication management. A supported employment and education specialist is really important. These are specialists that focus on returning to work and school, and basically provides this person with going through a first episode of psychosis with a coach to really help them achieve their goals. And then finally, case management. So case management is going to provide opportunities for people with psychosis to work with someone to address really practical problems and address any issues they have with accessing the services and supports that they need. So going back to Ethan, he's taking his medication, he's in a coordinated specialty care clinic, he's doing much better. He's not experiencing auditory hallucinations anymore, but he does sometimes feel suspicious of other people's intentions. He feels like peers at school can't be trusted, and he admits he can't logically explain this thinking, but he has been really anxious around peers. He's isolating from his friends, his teachers, and his soccer coach. He's also complained about struggling to read, and he says that the words on the page are jumbled and don't make sense. He needs significantly more time and a lot more effort for his studies, and this is really frustrating. And he's starting to doubt his ability to continue in school. So Ethan and his parents meet with the school, and the school recommends an IEP to support him. That stands for Individualized Education Plan. He's hesitant initially because he never needed extra support in school and always did well, but understands that things have changed, and so a few weeks later he agrees. Ethan receives an IEP at school. It's classified as emotional disturbance, and this allows him to receive several accommodations like reduced workload, the ability to receive materials and notes before class, and the ability to record lectures. He does drop from an honors math and English class to a regular math and English class, and that was suggested by the IEP team. And then he has access to a tutor 3 days a week at school. A study period is added to his schedule to allow for work completion. Okay. And I do want to say that this is like a disclaimer. This is kind of like an ideal case scenario with putting in place an IEP and having the student agree that this will be helpful, and having the school and the parents and the student all on board with the same plan. We kind of framed it this way because we really want to focus on the transition to college, but I also just want to acknowledge that a lot of times this process can be tricky as well. All right, 6 months later, Ethan is now a senior in high school. His psychosis has been well controlled for the past 6 months. And with IEP accommodation, he has passed all of his classes. He's preparing for his senior year of high school, and he's starting to wonder about college, just like all of his peers. His parents and teachers, or he and his parents wonder how to know if he's ready for college, and if so, how to approach that search and ensure he has continued academic success. All right, now I'm going to pass it off to Dr. Albert.
Hi there. So we're going to spend a little bit of time just talking about thinking about the transition and how to determine readiness for going to college. Understandably, Ethan's parents are really worried about his future. They've just been through this very difficult and challenging time of the diagnosis and recovery from his initial episode. And so now they're wondering about, how will his symptoms of psychosis impact Ethan academically and socially? How is he going to do in college? What are his options? And what is his academic potential moving forward? So how would we, and they're also wondering, how do they talk to prospective colleges about his condition? Do you disclose? How do you prepare for all of this? So I want to give you some perspective on how do we, as professionals, how do we think about assessing readiness for college? And I will say, I work with a lot of transitional age youth. I've done a lot of this type of teaching, and transition to college is difficult for anybody, right? Assessing that readiness. There's young adults that go off to college even without having a mental health condition that struggle. And so that preparation, I think, has a potential to go wrong for any college student, for any high school student transitioning, but especially for young adults with mental health condition, and especially a mental health condition like Ethan's, where it took him a while. It took 6 months for him to finally kind of get back on the path, pass his classes. And we know this about recovery from first episode psychosis, that it can take months sometimes to kind of get your footing back. So when we think about readiness for college, we want to sort of focus on understanding these domains of transition. And this is a way for us to sort of systematically think about different areas of readiness, and also be able to talk to our participants and their families, to young adults and their families, about some of these domains, and then an opportunity to assess, like, where are the gaps and how do we fix them? So these 6 domains that we think about are health condition, knowledge, and skills. What are the self-advocacy skills that the young adult possesses? Independent life skills, academic skills, and executive functioning, right? So how do they function academically? Are they able to do all these things for themselves, or are they getting a lot of help? And psychosocial development. So where are they with their development of identity and social relationships, and anticipatory guidance, some of the safety issues in college. And we're going to spend some time looking at each one of those and sort of discussing them. And then we'll sort of look at Ethan and where he's at and how to help him and his family prepare. So we can move on to the next one. So the first one, the health condition, knowledge, and skills, really refers to helping the young adult transition to taking on this role for themselves. So what is Ethan's understanding of what happened? How does he think about his first episode? How does he think about what happened to him? We have young adults in our program who will say, okay, I have schizophrenia, I'm in recovery, this is what I need to feel well, I need to take my medicine, I need to come to appointments. We also have other young adults who don't have as much ownership of what's happening and involvement in their own health condition, and that is more ripe for challenges. So for example, within this domain is, how does the young adult appreciate their health condition? Are they doing the maintenance, the day-to-day of their health condition on their own? So for example, for a young adult transitioning to college and getting ready to take on the adult role, are they taking their meds on their own? Do they know how to do a refill? We take that for granted as, prescribers, but it actually can be quite complicated of how to do that. So does this young adult do that for themselves? Do they know how to request a refill? Do they know how to do that with the pharmacy? Do they know how to go to the pharmacy and get one, pick one up? What about insurance? Do they sign their own medical releases? Do they know about some of those laws, like HIPAA laws in college? There's FERPA, federal education, privacy. Do they take their meds on their own, or do parents make sure that they take their meds? And other things are about, scheduling and keeping their own appointments, but also knowing their own bodies and what keeps them well. So knowing that I really need to have a consistent sleep schedule in order to feel well. I need to eat. I need to exercise in order to keep myself well. And so all of those are part of this domain, and assessing where the young adult is on this particular domain will help knowing how well they'll be able to succeed in college. So for example, for Ethan, if medication adherence is really important for him to succeed, and he decides to stop taking his medication, that might have implications of his success in college. Or if he, if the plan is for him to go away to college and he's doing all this, he's expected to do this on his own, and he's never done that on his own, that's a setup for failure. So this is an opportunity for the team, for the young adult and his family and other supports to sort of put that in place and assess where he is within the competency for this domain. We'll move on to the next one. So this domain is self-advocacy knowledge and skills. And this is all about kind of thinking whether the young adult is able to, is the young adult aware of federal laws that oversee university support? Are they aware of accommodations on campuses? What kind of supports are they entitled to? What kind of supports they need? How do I ask for those supports? So for example, and we'll talk a little bit about this when Phil Thomas starts discussing the transition on campus and what available supports are there. But a lot of all schools will have accessibility offices and disability offices on campus to help support a person with disabilities. And so is your participant able to do that? Do they know about what's available and how to find what's available? And it is more complex than just going to the office. You need proof that you have a disability. You need to find that office, contact them, send potentially a letter of support. And then once you get eligible accommodations, then you need to take those accommodations to each professor and ask for help. So is the young adult have those skills and knowledge of what's available to be able to implement it on campus? So ways that you might prepare for this so for Ethan, for example, he has an IEP. So in high school, is he participating in the IEP meetings? Because oftentimes students are encouraged to attend, but a lot of them don't. And so it's these educators and parents who are participating, but it's an opportunity for the young adult to take ownership of this and to participate and have a voice and asking for what Ethan might need, and recognizing when they need the help in school. So we'll go to the next one. Independent life skills is really important for an individual to succeed in college, because again, they're transitioning to the adult role and taking on more adult responsibilities like budgeting, cooking for themselves, laundry, especially if they're going to be moving out and not living with mom and dad. And so there's an opportunity for them to learn how to do these things on their own. Arranging transportation, managing their schedule, and just other basic activities of daily living. Next slide. Independent academic functioning is an important one that I do think is a little bit overlooked at times. I have seen a lot of young adults with psychosis, without psychosis, struggle in college because they weren't necessarily practicing this while in high school. So this refers to appreciating that there is college requires an increased cognitive demand. There's more, classes are more intensive, like can be more intensive. The pace is quicker, and you're expected to balance a lot more. So other things such as like writing papers, using source material, it just requires higher level of academic functioning. And ways to practice this in high school is, you know, I've seen a lot of students where mom and dad are doing a lot of the advocacy in high school, a lot of the schedule management, keeping up with assignments. So, you know, checking, we all now have portals that parents are access to, and they can see whether you did your homework or what's assigned. And that can be really helpful to help the young adults stay on track in high school. But it's not a sustainable model in college. And so as an opportunity for parents to sort of allow students to do that for themselves. And if they are able to manage their own schedule, make sure they're completing assignments, staying on top of tasks on their own. Speaking up in class and knowing what they have to do, what they're responsible for. Next slide. The next domain has to do with psychosocial development. And this is the task of most adolescents, is to figure out who they are and what they want, start figuring out what kind of friends they want to have, what are they interested in, you know, learning to drive, starting to hold down a job, coping with relationships, coping with their emotions and their emotional life, trying out new roles with friends, exploring interests and opportunities. And you can imagine with a young adult who's experiencing a first episode psychosis, that the onset of psychosis occurs at this critical time when the task of adolescence is to like figure out who they are, this identity development. And so it's an important one not to overlook, because all this is going to continue in college. And so if the young adult isn't ready to manage relationships, to be around others, to kind of know what they want to do, again, it can cause a lot of challenges in college. And so this is another aspect of transition that needs to be identified and looked at and worked on with the young adult. And the next slide. And the last one refers to kind of anticipating things that occur in college. So, you know, you're transitioning to college with psychosis or a serious mental health condition. You know, there's concerns about stigma. How is that going to be handled? What kind of supports am I going to have when I transition? What am I going to do there? Learning about managing roommates. How am I going to get along with people? Managing academic challenges. And so anticipating some of those challenges once you already pick a school, it would be quite important. So this one is a little bit further ahead. You know, we sort of addressed all the other domains first in terms of assessing transition, and then start actually planning for this one as well once you sort of pick a school. Again, how to manage access to alcohol and drug use on campus, as well as managing all the stress of actual college life. And so kind of working on that and anticipating it. We do have some transition readiness tools. And so I use some of these in the office. When I meet with young adults, there is a number of different types of assessments, and some of them will look at a number of different domains. So for example, a specialized transition readiness assessment, this is in the supplemental material for academic psychiatry. So I think that is copyrighted, so you'd have to access that. But that's like a very comprehensive assessment that has that kind of goes over all of these domains, and it allows the young adult and their family to kind of check off what are they doing, what are they not able to do, and then it kind of gives you a target for change. And then there's other ones. So I included in this presentation, just to give you an idea, for the transition readiness assessment questionnaire, it's a track. And I like this one, especially as a psychiatrist. It kind of addresses the health management and independent living skills. And it's a start for us to kind of start discussing transition and transition readiness and getting the young adult to think about, oh, gee, I guess I'm not doing that. Maybe I should start practicing. And sometimes like doing a questionnaire and an assessment, you know, you're really looking at what you should be doing, what you're not doing. It gives you like a target to assess and then measure at the next visit. I really like the JED Foundation, and that's set2go.org. They have a lot of resources on their website for transition, about transition. They have tools for universities, for colleges, actually, for them to increase their mental health literacy, as well as materials for young adults and families on how to prepare for the transition to college, or ways to start preparing early. And so these are some other ones that are readily available and you can find. So for example, Landmark College is a school that is actually really friendly towards folks with disabilities. So for example, ADHD or other kinds of things, that they really have a lot of supports, and they have an assessment tool that, you know, you don't have to go to Landmark College, but you could like look at that assessment tool to look at some of those domains. Move on to the next one. So this is an example of the track. I just included it so you guys can just sort of get an idea. So it includes like managing medicines. You know, do you fill a prescription if you need to? Do you know what to do if you're having a bad reaction to your medicine? And you know, I worked with somebody who said, no, I'm ready. I don't need any of this. And we did the assessment. And so he check marked all these, and then he said, huh, I guess I don't know how to do that. And so then we had a goal. And so by the next visit, he practiced refilling his medicines and then making the appointment on his own. And that really helped him stay on track. And it actually engaged him in the process. And he said, okay, I really do want to be more independent. I really want to do this on my own. So he worked with me on it. Whereas before he was a little bit more disengaged, and the discussion around transition wasn't as meaningful. And this way kind of helps the young adult and the family kind of work on this together. Oftentimes when we do this together, we find that the family is doing more, like the parents are sort of, you need to wake up, you need to go to school, you need to do this and the other, whereas the young adult isn't as engaged. But if you do this together, then it sort of moves, it gives the young adult some ownership. And then it also allows the parents to back off a little bit, which is what we need, right? We need the parents to encourage autonomy in the young adult. But they also want to feel comfortable and confident that the young adult is able to do it. So as opposed to saying, okay, now you're 18, you do this all on your own, we're sort of doing gradual preparation for more independent functioning. There's a question about having this materials. We can certainly, I believe this is all going to be available to you. And we can also add links so you can access some of these materials. All right. So there's domains on appointment keeping. If we go to the next one, this is just the last, the next page is just talking about health issues. Again, kind of helping them get ready for being able to manage appointments on their own, and kind of, what do you do in an appointment? You want to bring questions when you're talking to providers. You might want to tell the doctor or nurse what you're feeling. And then also there's questions on managing daily activities. So I like this one because it's only 20 questions. It's kind of easy. It doesn't cover everything within the transition domains, but it's a really good start, and it starts the conversation. So another way I've used it is I've given the questionnaire to parents and also to the young adult. And then we would bring it together if there's discrepancies and say, you guys don't agree here. How can we work together? How can you talk to your parents about how you see this versus how they see it? So it's an opportunity also for kids and families to have those conversations about transition planning. All right, let's move on to the next one. So looking at each domain is very helpful to assess a person's functioning within that domain. So like, for example, we use the track, and the track might help us identify the health condition, knowledge and skills, as well as some independent living skills. And for the other domains, we might use a different way to assess them. So for example, if you're thinking about Ethan, so Ethan was doing much better. He wasn't having active psychosis, and he was able to pass all his classes because he had an IEP, but he did have to drop down to non-honors. Before he was in honors, and he is taking more time to complete assignments. He was having some reading and focusing issues. And he was, struggling more than he was before the psychosis occurred. And so taking that in mind, we would want to think about where he's at right now, but also not ignore where he was before. So also kind of appreciating kind of how, what are the deficits that occur when he is more symptomatic, because you also want to plan for that in case that those symptoms return, or recognizing if those symptoms get worse, for example, with stress. And that is all part of kind of creating this type of plan. So one of the things that we start doing is we want to review the participants' functioning, current functioning, right? Including starting off with figuring out what do they want to do. Do they have post-secondary career interests? What do they want to be doing? Where do they see themselves? Our current, I guess, system or culture is sort of set up that this is what's expected. You're expected to go to college. You finish high school and you go to college. I mean, that's as opposed to there's other things that a young person might want to do. They might want to take a gap year. So college isn't the only thing out there. And then there's a different path for everybody, and it has to be very individualized. So having honest, open discussions about the participants' strengths and also their limitations. So if Ethan, before the psychosis, was hoping to go to Harvard and, major in, I don't know, pre-med or engineering or something like that, and it's a very rigorous program, you have to have a realistic discussion about, where he's at right now and what are his strengths and what are his limitations and where it's going to be harder or easier to actually make this happen. One of the other issues is on making sure that you have a definitive diagnosis and prognosis. So for example, for Ethan, his prognosis, I think, is very positive because he's not having active symptoms. He's actually functioning quite well. He was able to get through his classes. It doesn't sound like he's back to where he was before the psychosis, but he's definitely working in his recovery and doing well. Additionally, looking at the level of supports. So what kind of supports does Ethan need to succeed? So he is in a coordinated specialty care program right now, which is a program that, aside from his parents, provides a lot of support. So there is psychiatrists, there's therapists involved, primary counselors, there's a support education employment specialist. Probably our program, for example, has a peer specialist as well who works with the individual. So there's a lot of supports that are in place. And so one of the questions is, if he has a tutor in school or if he has a mentor in school, is that what helps him succeed? And so if that's in fact true, then we need to think about how much support is he going to need in a different setting and in college. So if the participant is thinking about going across the country to somewhere where he doesn't have any supports in a small school that is really far away from, you know, community supports as well as medical supports, again, that you could see that that might be a setup for a failed transition, as we call it. And also thinking about their short-term and long-term treatment goals and needs, like what does he need right now, which is what might he need in a year, or might he also, maybe he doesn't need a lot of supports right now, but at any point he might need more supports. And so then thinking about like anticipating and making sure that there's access to what he might need if he's having a little bit more difficulty. And then the last part of this is really, again, looking at those transition domains and then coming up with a plan to address those gaps in readiness. So, another thing that from the case, if you guys recall, that he would occasionally hear auditory hallucinations. So, and what we know about psychosis is that symptoms can sometimes increase in intensity, and it doesn't mean it's to the level of they're having another episode, but they might be more symptomatic at any point, and stress can certainly be can bring them on. So a little bit more struggles with stress. And so working on stress management during the transition, and so that he has really good skills on how to manage stress. Having more symptoms, like when you're around peers, thinking about what people might think about you. If you're on a campus and there's a lot of people you don't know, there's a lot of stimuli coming at you, that might increase symptoms. So again, like sort of anticipating and thinking about, given what we know about this participant and the symptoms that they might experience or have experienced, how do we anticipate some of these challenges and preemptively work through them so that they feel the most prepared, and then they're not upset or beating themselves up. Because for a young adult to do all this prep, they're so excited to go to college and get there, and things not work out, it can be really devastating. And so we really want to be proactive in helping folks succeed and when they transition. All right, we'll move on to
Dr. Alberg, I'm going to bring up a couple questions that came up in the chat, if that's okay.
Sure.
Michael Stepansky asks, when assessing a young adult's readiness, can you say more about the availability of external supports like the CSC and how that can moderate this, and how important a person's own assessment of their readiness is in terms of providing encouragement and support?
That's a really great question. So in terms of the coordinated specialty care program, what types of supports we provide? So Phil can speak to some of the things that he does with participants, but it would be on, it would be kind of the nitty gritty. Okay, what do you want to do? Where do you think you might go? And really going through specific options of transition. So specific college options. So if they want to take a gap year, or if they want to work, or so for example, Ethan, if right now he's able to carry a full academic load versus he's early in his recovery, but yet he still wants to transition to college, we might recommend, what about taking, think about taking one course and maybe not going away, maybe staying local. I'm definitely, I don't want to steal Phil's thunder, so I want to.
No, I actually don't mind speaking into this real quick before you move on. Part of what we provide as a program is to have a point of contact to help be a sounding board for their decisions moving forward with school, both with the supportive education and employment specialist and with the peer specialist as well. It's important to remember that adolescents going through this transitionary period often, as they leave school, no longer have that point of contact with a high school guidance counselor. They don't have the same point of contact with the special education teacher. And those supports do not go along with them. But with a CSC, we're able to support them in that transition. And there's a lot of nitty gritty, like Dr. Elberg was saying, that goes into going to school. For example, financial aid counseling, that often is a missed portion of deciding where to go to college. I'm going to get more into it later on in the presentation, but overall is that we are there to support them with anything that pops up and help them make a decision for what best fits where they are. And to answer your second part of your question, it is important about a person's own assessment of their readiness, because they have to determine what level of course load they can take. They have to determine where they are along in their recovery and how much they can handle at this given time, and how they can transition given where they feel they're at.
I also saw another question in the chat in terms of when should you start planning for the transition? And that is a wonderful question. And honestly, for any of these kids, and even without talking about psychosis, early, the earlier that you can do. And honestly, we actually start this very early, like middle school and things, in middle school, we even start asking them about, okay, you give the kiddo chores and have them start picking up for themselves, again, starting the idea of, exploring what they might want to do, encourage them to try on different extracurriculars, and just about exploration of what they might be interested in, and also on having the parents encourage them to work on independent living skills. So getting them to clean up, do their own laundry, start chores around the house. And in high school, just adding a little bit more around that, eventually talking about actual college plans. So what kind of school, how to go, do you want to go away, and learning about what's available. So the earlier you start, the better. Probably junior of college is doable. Senior, when we get seniors, it's more challenging because there's not as much time. I mean, we've even done this with somebody coming to us in like May before their senior year, and we just meet them where they're at, and we do as much as we can. But the earlier you can start, the more planning you can do, and you can do it slowly. It's not as overwhelming. And it definitely needs to be a collaborative process, and really needs to be able to address the needs of the individual and the needs of the family. And sometimes they don't agree on that. We've had kids sometimes where the parents say, well, they're doing so much better. They wanted to go away to school, and I really want them to go away. Like, they need to go away. Whereas the student is a little bit more hesitant, and they don't feel ready. They like the support. But we also had the other, the other way where the student says, no, I really need to go away. And whether it's psychosis or any other mental health condition, or sometimes this notion of going away to college is seen as, I can put all this behind me. None of this happened because I'm starting fresh. So it's not uncommon for young adults to say, I'm going to stop my meds when I go because I'm not going to need them. I'm getting a fresh start. I've seen this with young adults with psychosis, without psychosis. And so, taking the time to really address transition and those plans is very critical, because then you'll find out what people really think about it, kind of how they conceptualize. And for a lot of young adults, it does feel like a fresh start. I can just put all this behind me, and that doesn't actually help them stay healthy and continue within their recovery, because then symptoms often come back and things fall apart. With regards to having a robust plan, definitely identifying stakeholders. So like obviously the young adult, the parents, what providers are involved now, what providers are we going to need moving forward? Do they have other supports? Like, for example, a community support group. If they really rely on the community support group or the other social supports, and they're going somewhere where that doesn't exist, that would be quite challenging. Or if they need some sort of special treatment program, like a CSE program, then oftentimes that needs to be a big part of the consideration. And because, for young adults who are recovering from their first episode of psychosis, this is very serious. And so the consideration for ongoing treatment and the need for ongoing treatment has to be a primary part of the transition plan and not an afterthought. And so kind of figuring out where the young adult and the family is, and over time, kind of getting them thinking about that and collaboratively working on that transition plan will go a long way and will help with a successful transition. We often talk about transfer of care plan. So determining, like, are they going to be local and they can continue with the same providers? Are they going to go away and then have something there whatever school they're going to go to, but also have support when they come back from college? So sometimes a dual treatment is needed because a lot of the schools, like if the kiddo is going to come back home for breaks in summer, the schools and the treatment providers might not be able to continue treatment, especially if it's out of state. So for example, like telehealth options are not an option for treatment across state lines anymore. So during the pandemic, that was waived. And so thinking about that and kind of how we're going to do it, also emergency care, like if there's an emergency, what are we going to do? So having a really robust transition of care plan is very needed. Other things that we start doing is we talk about treatment adherence, right? And what are the challenges, like I already said, that might be encountered while in college, again, with stigma. So I don't want my roommate to know I take meds. Okay, so how will you negotiate that with your roommate? So again, bringing that up and proactively working on that. And then thinking about history of stability, and then knowing, so we call that in our program, like in the CC programs around relapse prevention. So young adults will work on a relapse prevention plan so that they know what the warning signs are. So then we intervene before things really get out of hand, and then functioning is impaired. We'll see if there's other questions or if we can move forward. So
yeah, and so to emphasize also, depending on the state, right, this is actually a good thing, is that part of the IEP process, especially for a first episode, is they would be creating the IEP while they're in high school. And part of a high school creation of an IEP is a transition plan moving into college. Now, it will not be as robust, but it gives a good starting place. For example, they would be talking about the post-secondary career, interests, goals, dreams, strengths, limitations, plans on where they're going to be living come the transition to college. So these are all important factors that are actually placed into an IEP and part of the IEP team meeting that would occur. And it's actually made from the opinions given by the student themselves. So with their buy-in, it actually helps them start thinking about what their plans are moving into college. Now, to shift here just a little bit, I wanted to take a poll on some of these questions over here. The first, and I want to see what everybody has, and feel free to toss it in the chat. Should Ethan's parents talk to colleges about his diagnosis? And I'm just very curious as to what everyone thinks the answer to this would be. Whew, I'm seeing a lot of split decisions here. However, I am seeing one that was a perfect answer with the FERPA permission there. So here's the deal. Parents can be involved if the student allows it. However, colleges want students to advocate for themselves. 100% they need to be involved in the process. And the biggest shift here from high school is that there were other people working towards the accommodations and the things that the student needed in order to succeed in high school. However, during the transition to college, all of the onus is now put on the student. And this is difficult because they're coming from a season of trying to figure out how to even go back to school in the midst of the diagnosis they have. And now, while going into college, they have to figure out all of the paperwork, all of the classes they want to take, the accommodations they want to receive, and they have to do it themselves. Yes, like I said, parents can be involved if the student brings them in to have that discussion with the accommodations offices. Even with the FERPA form, there's a lot of situations where colleges will not give accommodations unless the student specifically advocates for themselves. So yes, they can be involved, but no, they should not be giving any information about the diagnosis without the permission of the student. Second, can IEP accommodations translate to higher education? I would love to hear everyone's opinion on this. Maybe tailoring it. I love these answers. Yes, no, split again. This is why I love these 3 questions, because it's really down the middle. Here's the deal. Once again, it's one of those yes and no situations. I love trick questions. No, they will not be directly applied to when the student comes to college. For example, if they had a certain accommodation in high school, that does not necessarily mean that the college will automatically give it to them. However, it provides a list of accommodations that they can advocate for with the college. I always suggest to my students that I work with that they keep their IEPs, especially the parents, because part of the IEP process is sending the IEP to the parents once it's created. So having that list of what accommodations are available to them or what they succeeded with is important when they transition into higher education. So yes and no, it's important to have, but that does not necessarily mean they will receive it unless it is deemed appropriate by the college based on the documentation they submit. Okay, final question. Is it difficult to be approved for accommodations at a university versus an IEP in high school? Love this split back and forth, saying no, it shouldn't be. Great answers. So once again, this is a yes and no situation because the IEP process is not pushed forward by the student. It is pushed forward by the parent and then a team that will meet together to provide accommodations based on how appropriate they are. When it comes to the university, the onus is once again on the student to provide the documentation that lists what their diagnosis is and what accommodations are recommended for said diagnosis. So it is not difficult to be approved for it, but it is more difficult in transitioning into getting those accommodations because the student, while going through the experiences they're having, while going through the diagnosis that they have to submit it all themselves. So it puts a lot on the student. And keep in mind the age group, right? We're working with students who are 17 to 18 years old. I'm sure every single one of us can think back to when we were 17 and 18 years old, how good we were at submitting paperwork that we needed for college. And now we're putting the onus on a student who also has a diagnosis where they would struggle with remembering these certain things to get done. So yes, it can be difficult with accommodations at the university because of how much is put on the student. If you don't mind going to the next slide. Yes, and I just want to address one thing right at the bottom. I think Pamela just said it. You suggested that parents contact colleges regarding if there's accommodations for their child. I will say that it's state mandated that every single college does have accommodations available to students, but they cannot advocate for their specific student without having a FERPA form signed. And on top of that, accommodations will not be provided unless the child themselves advocates for them. And that's just how the colleges are run, because you have to realize once they turn 18, these students are now adults, and the universities are seeing them as adults. So a lot of the responsibility is now expected to fall upon them. So advocating for college accommodations. These are all suggestions that I actually have that from my personal experience have helped with this transition as a whole. It's holding on to all prior IEP and 504 accommodations and psychoeducational testing, because it is documentation that can be provided to the colleges in order to advocate for the accommodations that each one of our students would need. IEP transition goals, like I just said before, is that part of the IEP process is creating those transitionary goals, where you want to go with school, what plans do you have to move forward, is grad school in the plans for what you want, do you plan on working during this time in college? All of this is added to the IEP, and it helps students to start thinking about what college will look like for them, because you can imagine for students who are in high school, a lot of them are not thinking about the future nowadays, probably more so than it was in the past, but a lot of them are not thinking about the nitty-gritty that goes into that transition into college. Now, some resources that they have available to them that often they don't realize that they can talk to, but throughout their entire high school career, they have a high school guidance counselor and a special education teacher that is going to be more well-versed in what they can request from colleges. Are every single one of them going to be perfectly educated in this? No. However, it does provide a baseline for what they can advocate for. It's important to remember that the special education teacher has worked with them since the inception of the IEP, and then depending on the school, sometimes the special education teacher will move up with them. Often it'll be a warm handoff to another teacher, depending on the grade level. So they will know what is best for the student and what type of accommodations have worked for them throughout the course of the IEP in the high school. So it provides both students and parents with a baseline for what they should be asking for or should be requesting when they transition to college. And lastly, it's knowing your Office of Accessibility and Disability Services. I can't tell you how many times that I've gone to schools and nobody knows where the office is, who the point of contact is. And it is a huge transition for these students, because when they were in high school, they had a point of contact. Like I said, the special education teacher, they had high school guidance counselors, they had individuals who were following them and helping them determine what they needed in order to succeed. But when it comes to the school, they don't have that point of contact. A lot of that onus is now on them. So being in contact with a representative from the Office of Disability Services that you can actually message throughout the school year, that you can actually reach out to via email, is essential to the process, especially because every single school gives these accommodations in different ways. I think I saw earlier in the chat, somebody was talking about how their daughter, all they had to do was register, and then the Office of Accessibility Services would reach out to their professors. This is not the case in every single school. There are schools where the student would have to come to the office every single time they want to request a specific accommodation for a test. There are times where they're approved for accommodations, and then they have to send all of that information to their professors. So a lot of this is put on students, and they have to check their emails. This is actually something that is often even forgotten by a lot of students. So accommodations can be difficult depending on the school that you are at. If you don't mind moving to the next slide. And that's why searching for the right fit is so important, because not every single school is going to be the best fit for every single student, because they don't have what they need at every single school. For example, there are schools that provide certain accommodations that others do not. Private versus public schools. And knowing what capabilities a private school has versus what capabilities a public school has, and the funding for the specific department of disability services, because some schools have it very well funded while others are underfunded in that department, which would affect what accommodations they can even request. For example, if they are looking for assistive technology, some schools will have that readily available for all of their students because it's a subscription-based service, while others in that department are underfunded and will not likely have that accommodation. So really, it comes down to searching for what fits best and what supports they have as a whole. Now, Part of searching for the right fit is also, one, it is looking at the college, but two is looking for the supports that you have available around you. And that's why I put the supportive employment and education specialist as part of a CSC program. Being near one, because like Dr. Albert was saying earlier, it's hard to stay connected to a program if you choose to move away from your local school area. There are other CSE programs in different states and different cities. However, knowing who you can contact, trying to get plugged in with those programs are essential to a lot of people in seeing success in college. And specifically within supported employment and education, because it helps them put out fires when they need to. Often there are paperwork issues that happen that people don't even realize happen in the moment. And knowing that you have a point of contact that is there for with that short period of time to help you get through this short time in college. And in terms of looking at college characteristics, knowing your housing options, knowing the numbers of students and the class size, because there are students who in high school, because they were in IEP, were in a limited class size. Some of them were in 811, some of them were in 1211s. Going from that to a class size of 30 to maybe even 50 and maybe even 80. I've seen lecture halls that hold a ridiculous amount of students. We're taking a student who is used to having not more than 12 students in their cohort that may have a difficulty transitioning to a class of that size. So knowing how big your university is. In-person versus virtual classes. I can give you so many examples of when students meet with their academic advisor, and because a certain set of classes are on their requirement listing, they register for them for those classes and fail to let them know that they are virtual classes. And often students who have a diagnosis or students who had an IEP in high school struggle with keeping up with the work that is involved in virtual classes. Knowing that they have access to healthcare services, like I said before, and location, because it really affects the natural supports you have. Having your parents around to support you, having your old friends from back in high school, having a place where you don't feel like you are alone. It really does make a huge difference in that transition to high school, from high school to college. And one more thing about the school-specific accommodations is that between private and public schools, the public schools are often well-funded, but the private have less restrictions in what they're able to give to a student. So really the right fit makes a huge difference. For example, for private schools, often they can give an accommodation that lets students maintain a full-time status with the school while only having a part-time schedule. Public schools make it way more difficult to receive that accommodation because they need a lot of documentation behind that. And for a lot of students transitioning from high school to college, having a lower class load is essential to their success. However, it does affect their financial aid and how much they receive from the government in order to pay for school. So knowing what schools have that accommodation would provide you a big service. If you can go to the next slide. Now, I wanted to take some time to go over what specific accommodations are actually available for colleges, specifically housing and academic accommodations, and how different schools can provide different levels of each. For example, housing accommodations is something that is often overlooked because both parents and students are used to academic accommodations if they're coming off of having an IEP in high school. Many of them know that they can get extended test times. Many of them know that they can get a separate testing location, but housing accommodations in terms of having limited people around you, maybe even being approved for your own dorm room. These are actually all possibilities through the accommodations offices. Another possibility is even changes to the housing itself. For example, for those who have physical limitations, they'll change doorknobs, they'll change a cabinet handles, they'll even change the appliances that are available to make it accessible for the student, as long as it's backed up by medical documentation that notates that this is something that they truly need. So if you can go to the next slide, I actually have a list of accommodations that are available. But I want to say this, the list of accommodations is not a limit. Everything that's written here is not the only things that are available to students. Really, the scope is not beyond the imagination of what the student wants to advocate for. Really, that's what the college wants. If a student goes to a disability office, they generally will not give them a list of accommodations that they can pull from. Once they register with the office and they submit the documentation, these students are required to ask for what they need. It's not on a list. It's not a one-size-fits-all. It really is tailored to what the student needs to succeed. And in order for that to be true, it has to be coming from the student, and it has to be something that they are requesting specifically. And if it's within the power of the college to make it happen, often they will make it happen. For example, there are students who would thrive with assistive technology for note-taking, but there's some who would need an individual scribe that is there to write the notes for them, but they have to ask for it. So it really comes down to self-advocation. And that is the biggest transition, honestly, that I can't emphasize enough, that students will find a difficulty in that transition because they are now forced to kind of advocate for themselves. And this is why it's so important to be linked in and know about a local CSC that you can be part of, because it provides a person to advocate for you. In our specific program, the supportive education and employment specialist is there to advocate for them when they have a difficulty doing so. And in having that point of contact, it is somebody that their counselors can reach out to, their academic advisors, even financial aid. Once that FERPA form is filled out, it becomes that point of contact to make sure that the student sees the most success in their academics. Because with that transition, what CSCs don't want to see is that a student fails, because it really sets them back both in their recovery and with their long-term future and personal goals. So advocation, it really is what matters the most. So knowing these types of accommodations, knowing that they can advocate for their extended time, use of computers for exams, clarified directions, test question readers, permissions to even take medication or eat during exams. These are all possibilities, but it has to be asked for by the student. Now, does anybody have any questions about accommodations, or what is within the scope of what a school can provide? Really, I'm saying housing is a huge issue for us right now. My kiddo is getting ready to finish. As soon as she cannot qualify for on-campus housing, she has to drive. Okay. Percent important for her to stay on campus if she has to navigate very like she makes many classes. Okay, so housing can be an accommodation. It depends on what your student would need. Like I said, they do physical changes to the housing situation based on the needs of the student. The request can be appealed as long as there's medical documentation to go along with it. For example, I recently had a student who was denied for certain accommodations because there was not appropriate documentation to go along with it. But once there was a letter from our specific program detailing why it was necessary in order to have those accommodations, it was approved. Now, I can't say with 100% accuracy that it would happen every single time, but having a point of contact to advocate for why those specific accommodations are needed is more important, because it provides a space for these colleges to feel reassured that this is an accommodation that truly is needed by the student. I've written oh, sorry, that was Dr. Albert. Are there any other questions?
I just want to say thank you so much to everyone who spoke today. All of this really useful information. I want to end with this list of resources. Some of it is database resources. Some of it is general early psychosis resources. You all will get these slides at the end of the presentation. And then really I want to open it up, as Phil has started to do, to questions that anyone has had on any of the material that was covered, directed to any of our speakers. And we're happy to answer those questions or any discussion points anyone would like to bring up.
I did want to just mention one thing about healthcare linkages. And so a question that often comes up from parents and students is, why can't I go? I want to go away. And most of these places will have student health, and I can see providers on campus. And I don't know if that's been true for you. But oftentimes, if you go on the specific college's website, on-campus health supports, especially mental health supports, are very limited. They have a limited amount of visits, and they're really set up to help support the student with academic difficulties and emotional challenges that occur. We do know that there's a mental health epidemic on college campuses, and so most schools really can't support the entire student body, and especially if students have significant mental health challenges. And most schools, like just the other day, I sat with a student and we went on a particular college's website, and it says specifically, students who have a diagnosis of schizophrenia, bipolar disorder, major depressive disorder, we recommend off-campus linkages, because they just can't manage it in a robust way. Some schools don't have psychiatrists who are in the college campus office. And then there's also other issues related to health insurance on campus in order to be able to use those services. So again, that's university specific. But I know this question does come up, and if people want to discuss it more, but I did want to address it, that usually for young adults with a first episode psychosis or a mental health condition that involves psychosis, usually it has to be off-campus resources. The on-campus resources are inadequate, and the school will flat out refuse it most of the time.
And just to add to that layer, oftentimes these students have established care with a psychiatrist they really like, and then when they move out of state, that creates additional implications. If that psychiatrist is able to see them while they're out of state, that's a whole layer. I know that a lot of students prefer to, for that reason, sometimes go on to like the once a month injection type of medication. That way they can kind of get their injection. They only have to go back home once a month while keeping their visits. And so making sure you're troubleshooting all of those logistics before they leave for college is really, really key to ensure that they have access to the care that they need.
I have a question. I just wanted to know what suggestions can you give to address the negative symptoms that are usually caused by the medication itself, in order to be successful in school? Because I've already tried with my son to go and sit in some of the classes, but his lack of concentration just overwhelms him, and then he decides not to enlist. So is there any specific accommodations or suggestions or recommendations in order to help them be successful with the negative symptoms?
I think it's a multi-pronged approach. Negative symptoms are tough. I think that's the toughest part of treatment. One of the treatment approach for that is looking at the medications closely and seeing if adjustments need to be made. Sometimes people can get away with a slightly lower dose of the medication and without experiencing worsening of some of the hallucinations or other sorts of symptoms. And that might improve negative symptoms. Sometimes a switch to another medication might be helpful. So the medications can be looked at. That's one way, one approach. The other approach is looking at supports and kind of meeting the individual where they're at, and making sure that they're kind of engaging in treatment and having a lot of support. It's very difficult when they're not motivated and the family is like expecting them to be motivated and expecting them to do all these things, and it's part of the illness. And so just kind of meeting the individual where they're at and taking slow steps towards where that individual's goals are. Like if their goal is to maybe improve their grade in one class rather than across the board get straight A's, I think like taking those small steps and encouraging them and providing praise when they are able to take those steps is really key.
And
Oh.
sorry, I was saying, just like Dr. Bott was saying, that it is a multifaceted approach. So having appropriate accommodations to help with a student experiencing those symptoms is important. What I would suggest actually is more than one. One could be notes prior to the lecture, because it provides them the information beforehand. Recorded lectures, so they can go back through the lecture at their own pace, either at home or at the school library, whatever they want. It just gives them the space to go back through any information that they may have missed at their own pace. And one essential one would be accommodations for attendance, because there's a lot of schools that have attendance policies. If you miss 3 lectures, you automatically fail a class. So having accommodations for if there is a particular day where a student is experiencing a lot of negative symptoms and they can't make it to that lecture, having that recorded lecture to go over at their own pace later on and not having the expectation to attend class on that day would make a huge difference. Now, some schools will require some kind of documentation, like, hey, they had to see their doctor on this day. As long as whatever clinic that they're connected with can provide them just a letter of support saying that they missed this class on this day because of X, Y, and Z, that would be more than enough for what a school needs.
And I guess I would also just add that. Sorry, go ahead, Dr. Huff.
Where I might think about taking things slowly, as in like taking one or two classes at a time instead of like 18 credits, and like just making sure there's enough time to really focus on that class and do well and to retain the information. The other thing is, I think in terms of accommodations, a lot of schools offer like note sharing services. So not having to worry about getting everything down in their own notes, but being able to have access to notes from other students can be really helpful too.
I was just going to add that a lot of times the cognitive symptoms, especially with psychosis, schizophrenia, is very common. So in terms of motivation, concentration, memory, judgment, kind of planning, a lot of those things can be affected. And I guess one other idea, this would be more with the treatment providers, is to see, do they offer any cognitive remediation, any other services to address helping the student practice those skills. So like, for example, we just started a cognitive group, the cognitive remediation group, to just kind of help young adults practice some of those skills. And so asking the treatment providers and what services they offer, and maybe they don't offer, but maybe there's other resources in the area around that, because these are very common issues that come up.
One thing I want to address, because I just saw it in the chat, it says maybe taking one course over the summer. One thing to be wary of is that a lot of summer courses, especially nowadays, are virtual. I came across this for a lot of my participants that signed up for summer courses because they were suggested to take it, just to increase their progress towards their school. So knowing what classes they're signing up for and if they're able to maintain the level of work required for a virtual class, and knowing when it's time to drop or add or to withdraw, because there are a lot who will try their hardest and then take the grade at the end of the semester that would not be beneficial to them long term. So awareness goes a long way, even with summer courses. And that's another great thing. Summer classes are meant to be a full semesters in a short, small summer session. So it's going to be very, very quickly done. And for a lot of participants of programs such as ours, it is a difficult transition, fast paced.
Any other questions or comments from our audience? Okay, well, I will go into our wrap up. Thank you so much for joining us today. If you missed the beginning of the session, just want to remind you again to be on the lookout for the follow-up email that you'll receive after the session. In the email, you will receive your certificate of completion, a link to the to the recording of the webinar, and a copy of the slide deck presentation that's being shown. Okay. And then just a reminder to stay connected with us at NTech. On our website, you can find upcoming events and archived recordings, request support, see our publications and resources, and sign up for our newsletter. And we also are on social media, so welcome to follow us there. And finally, your feedback is important to us. In order to keep bringing you these free resources, we would love to hear from you. Your completion of the survey is a very important part of our quality control and to our future funding of this project. It allows us to continue to provide you with resources and training at no cost. In addition, it allows us to continually improve our services and provide the information and resources you are needing in the field. If you could please take a few minutes to let us know your thoughts, it would be greatly appreciated. You have 3 ways to access the survey. The link will be put into the chat. It will automatically pop up in your browser when the webinar ends, and it will also be provided in the follow-up email sent after the session. So please take a few minutes to complete the survey. Your time and feedback is valued. All right, I think that's it. Thank you so much, and have a wonderful Friday. Have a wonderful weekend.
Thank you, everyone.
Thank you, everyone.